Assisting Hands for another engaging and important discussion. And before we dive in to the discussion and you meet your host, let's meet some of the team from Assisting Hands. We've got Brett Sanders, who is running the Virginia office. And Brett, tell us a little bit about yourself and the region that you serve.
Yes, thank you, Steve, and also Steve Loberbaum for inviting us to have this topic as a topic that's near and dear to my heart. My name is Brett Sanders. I'm with Assisting Hands in Northern Virginia. We cover all of Northern Virginia. My office covers Arlington, Alexandria, and Fairfax County.
Fantastic. Thanks for joining us, Brett. And now let's meet the your host today, Steve Loberbaum with Assisting Hands. Steve, before we dive into this, tell us a little bit about yourself, your team, and the office that you run.
Sure. So my name is Steve Lorberbaum. I'm the owner of Assisting Hands of Potomac. We serve all of Montgomery County and the northern part of PG County. And I'm a lawyer and an engineer by training, and I came to this because both my parents passed away from cancer many years ago. They didn't get hospice, and because they worked with oncologists who are warriors and they don't give up. So this is a really important topic to me because I think a lot of people need to understand what hospice can do. Patricia DeBroof works with us. She runs our education and community outreach department. We focus a lot on educating people about the kinds of services that not only we provide, but that hospice can provide, durable medical equipment, and even things that you can provide in the pro-aging community. So thanks for having us today.
I love it. All right. I tell you what, Brett and I are going to duck behind the curtains. We're excited to hear this engaging discussion. Folks, make sure you ask plenty of questions. Use chat or Q&A. Steve, I'm really excited to sit in on another amazing discussion with you today.
So much. And I always appreciate Steve hosting this for us. This is really important topic today. So I'm really fortunate to have two folks that I think are just masters of hospice and explaining it and the sort of death and dying process. So first, I'd like to introduce Dawn Bolton with Frederick Hospice. Dawn, just give us a little rundown of you and Frederick Hospice.
Sure, thank you. I want to thank, first of all, you and Steve for inviting me, and Brett. I'm very grateful. Patricia and I have worked before together. Our hospice, Frederick Health Hospice, serves Frederick County and Montgomery County in Maryland. We're very blessed to have a thriving team of expertise that care for our patients. Personally, my story is I have been a nurse for many years. Critical care and emergency department were my specialties, and then I moved into hospice about 8 years ago. And having these hard conversations where I was stationed primarily was in the hospital before I moved to the community, and had these conversations where we were going full steam ahead, and all of a sudden plans have changed. And how do we go ahead and advocate for you as a person and respect where you are and get the quality of life that you certainly deserve? I'm very proud to work for our hospice.
Excellent, thank you. More questions in a moment, but I also want to introduce Tina Workman, who is here in dual capacity as a person who has benefited through family members who were on hospice, both at Frederick and other hospice organizations throughout the United States, and is also a death doula. And Tina, tell us a little bit about what's a death doula, just so that we can set that stage.
Hi, thank you guys for including me, the two Steves, inviting me and Dawn to participate in this. A death doula is someone who comes in and meets the pieces that hospice isn't able to, and they work in conjunction in support of hospice. Because they have the time to be there. They could do anything from helping somebody downsize their belongings, create legacy projects, take them to their lawyer, their financial provider, just hold space with them, advocate for them, just be a presence there for them, making sure that their wishes are met.
Okay, great. Thank you both. We'll get back to your personal experiences in a minute, but first I want to talk about, look, there's hospice and then there's now palliative care is a term that's thrown around as well. Can you explain what's the difference between the two, and how does one decide they need hospice? What's the triggering event? This is a function of Medicare law, if you will, and regulation. So can you expound on that a little bit and just help us set the frame of when is hospice a thing?
Absolutely. Palliative care is hospice care, except it's a larger piece, and then hospice is the smaller piece in that. So palliative care is when you've been diagnosed with a disease that could be terminal or chronic, heart failure, cancer. It can be a disease that has multiple symptoms in it that need to be managed. Sometimes the treatment for the disease causes the symptoms. Sometimes the symptoms are caused by the disease itself. So you see a specialist in palliative medicine, and palliative medicine helps you manage those symptoms while you're still receiving treatment. When you get to the point where treatment is not working for you, it's impacting your quality of life, it is becoming more and more difficult to maintain that level, or you're just exhausted and tired of constantly going to the doctors. Hospice may be a great choice for you, whether you're having symptoms or not. But hospice would treat all of your symptoms, your medical symptoms as far as pain, nausea, shortness of breath, and also your emotional and your spiritual symptoms. Sometimes we forget that emotionally it is exhausting to deal with a chronic or a terminal illness. Been dealing with it a long time, and hospice allows you that support as well as medical and emotional support and a spiritual factor as well. So when the right time is to get hospice is when you've decided or you've talked to your doctor and you've made a joint decision to say treatment isn't in the best of for me. I've decided I need to have a level of care that is something that is focused on quality. So when I'm having a good day, I don't need to go to another doctor's appointment or go get lab work done or have IVs done. I can stay at home. I can have services come to me, and those services are available 24 hours a day. So I don't need to come out to the emergency room in the middle of the night when I don't have any other recourse for support.
Gotcha. Okay. And so my understanding, though, is Medicare has some basic rule or framework that says that two people have to conclude that there's a more likely than not chance that the disease you're suffering from will cause your demise within 6 months, something like that. Is that
Correct.
close enough?
Correct. Often when two doctors, two providers, two practitioners have concluded, one is our medical director. She needs to sign off to say that you are hospice appropriate, that either continuing treatment or without treatment, your death is likely within the next 6 months. When we are talking about that, often it's because the treatment could be making you even more symptomatic and decreasing your longevity, so to speak. So you sometimes go on to hospice services, and with a disease like dementia or even heart failure, you could graduate off of hospice because with consistent care in the home, it's actually a beautiful situation for you to get better. Often people graduate, I would say, in our hospice about once a week. We have people graduating, which is wonderful. That means that we've done our job, and then we allow people to also say, you know what, I am going to go on hospice services, but I'm still young in my disease. And I know without treatment, I'm probably going to die within the next 6 months. My quality of life is declining, but I want to enjoy whatever time I have left. So the earlier you come on hospice, it allows you to have that time to enjoy. You do need those doctors and those providers to say 6 months or less, though, would be where you're going to be at as far as closer to death.
Gotcha. I'll give you an example of that. My father-in-law lives down in Florida. He has dementia. He has some heart issues. He went to the hospital a number of times, and they finally said, you know what? This is a heart issue that we cannot address, he doesn't have long to live, we recommend he goes home on hospice. So he went back home on hospice. He has care 24/7 from a home care company down there. And that was about 5 years ago. Because of the quality care he received at home, he recovered his strength, he recovered his endurance, and he graduated from hospice. And he's at home, he's super happy, he's living his best life, and he would not have recovered, I don't believe, had hospice and all of the basket of services that hospice provides come in to assist with his care at a time when he needed it. Let me ask you this then, and Tina, don't think we're not going to get to you.
No, I'm good.
But so tell me a little bit about what is the basket of services that people can expect generally from hospice. I realize it may vary between hospice organizations and what they add and don't add, but what's the general basket that people can expect to get?
CMS, who is the rulers of all insurances out there for reimbursement, states that all hospices have to provide nursing services, and those nurses come out once to twice a week, more often if needed, definitely every day at the end of life. They also have aides that can come out 2 to 3 times a week to provide as far as bathing, getting you up, washing your hair, those type of events. Sometimes we even have aides that go into home and they go 2 to 3 times a week and they spend time with the patient as a socialization, making them lunch, doing a load of laundry, getting it back on the bed. Those visits are short though, so we can't spend a huge amount of time with our patients as we wish to. And that's where getting a home care company like Assisting Hands would come in. The aides and the nurses work very close together because the aides see the patient so much more. They really are those frontline eyes. The chaplains, they come out as needed. Some people don't feel that they need a chaplain because they don't feel that they are religious of their past life. But often the chaplains just perform a presence, a spiritual guide to say, I am getting close to the end of my life, and these things that I'm beginning to feel are really becoming difficult for me to manage my emotions. So the chaplains are wonderful. We also have social workers that come out. Everyone is assigned a social worker. Those social workers do things like recommend home care companies. They also recommend level of cares. They offer counseling. They offer dealing with almost everything that's non-medical, where the nurses are taking care of. And then in our hospice, we have a veteran liaison to honor our veterans. We have and that also makes sure that the paperwork is taken care of to allow the spouse to continue receiving benefits after the patient dies.
Okay.
We also
Let's
have a
hold
music.
off on that.
Okay.
Because veterans are a whole special group.
They
We'll get to
are.
them as well.
They are. We also have music therapists that come out and they
That's
work
great.
on legacy projects. And I can talk about that. I've got some beautiful stories about those music therapists that we have. We have volunteers that also are part of just sitting with the patient. The patient sometimes just needs a presence there so the family can go to the grocery store.
Right.
The family can attend their own doctor's appointments. And then we also have doulas. Our doula program is a volunteer doula program that sits with patients at the end of life, but also works with patients on those legacy projects like Tina mentioned.
Gotcha. And
I'm
so
trying to think if I've missed something.
Bereavement.
I don't think so.
bereavement counseling.
Oh, bereavement. So sorry, bereavement. Bereavement is also required by CMS. We have a thriving bereavement program. We offer individual counseling, group counseling. We offer camps for children, and these counseling programs are whether you are in hospice or not. It's about taking care of our community and making sure that our community stays healthy. We also have camps for children that are free. We have different group activities because often people are left out. Those teens and those young 20-year-olds, they've had losses that affect them greatly. So we want to make sure we take care of them.
Gotcha. So let's get into a few things that hospice doesn't allow, or once you're on hospice, you can't get, because that's always the question that the big concern people have is, if I go on hospice, that means I'm giving up. I can't have other things done. And so the question is, I'm going to ask you a couple of things and just quick yes or no, maybe. And that way we can run through a list and we can always come back to it if people have questions. But things like OT and PT, is that something you can't have once you're on hospice, or you can?
So sometimes you can have that. It is dependent upon the hospice that you have.
Okay.
The most hospices do not cover it, and that's because you have progressed to the farthest you can, and you're not continuing to progress. And that's actually an insurance guideline. If you've progressed to a level and you are not going to progress any farther, PT and OT is usually ended. We will do a PT evaluation in our hospice to make sure that you are at the highest level, because we don't want to take things away from people. So PT and OT usually are not part of a hospice plan of care, but we do recommend families and patients to continue to do their exercise to maintain strength.
Okay. If I'm on chemotherapy, can I continue to get chemotherapy treatment for a cancer?
So chemotherapy treatment would not be covered under hospice, as well as things like, most of the time, IV antibiotics. So IV therapy is not covered under hospice care. Chemotherapy is not covered because often you need a lot of lab work, a lot of follow-up for the doctors, and your plan of care is more palliative based, even if you have you have a terminal diagnosis from the cancer, a stage 4 cancer. But if you've at that point where that is not helping you, or the chemotherapy is causing some symptoms that you find unacceptable to your life, or you're not able to receive it because of the symptoms, then hospice might be a good plan of care.
Okay. So what if I had some, we'll call it a growth, that was impacting my breathing, and by removing the growth, it would improve my breathing. It's not going to impact or lengthen the quality but change the longevity of my life, but will improve the quality of my life. Would that be something that would be considered?
Actually, we would recommend you to follow up with your thoracic surgeon and have those items looked at before you get into hospice service, because there may be complications that are involved that would not follow up with our hospice plan of care. But we do drains for people. Sometimes you have accumulation of fluid in your lungs or in your abdomen, and drains really help provide a higher quality of life because the fluid can be removed. And our hospice does that very frequently. That's really important. We also do things like put people on medications sometimes that make feel better, like steroids. Steroids are very common under our cancer patients because it reduces inflammation. Inflammation in that tumor causes pain. So often our patients are on steroids as well. So it's a common misconception that hospice takes away all therapies, like therapy to have a drain placed or medications. But often we do. We just do it in a different manner, in a different individualized plan of care.
Gotcha. Okay. So Tina, you've had several experiences where you've had the benefit of hospice for a loved one. Can you share some of your experiences about how that may have improved the journey for both you and for your loved one?
Sure. The first case that I had, the first incident was my mother was in hospice in Texas, and she was in hospice. She stayed at their facility and they cared for her because my brother wasn't able to care for her at home. And they were very loving and kind and treated her well and made sure she was well taken care of. And it allowed the family to breathe easy because we knew that there were people there taking care of her. My sister, she was in Pennsylvania, and she was in a nursing facility in Pennsylvania, and she wanted to go on hospice. That place, the hospice there was not very easy to work with. And I wanted to bring her home. So I contacted the Frederick Hospice, and they contacted the facility, made the arrangements, and I went and picked my sister up and brought her home. My sister was not an easy case. She had complications due to diabetes. She was blind. She could not walk. She could not feed herself. She had a feeding tube. She had a colostomy bag. She had tons of issues. And hospice was so amazing. The nurse that came and did her assessment was so thorough, explained the process to us in great detail. The nurse that was her care nurse, anytime we picked up the phone and called, they were there. Somebody was always able to answer our questions. The aides that came and bathed her were amazing. My son and I were the ones that were home with her. And when he was there by himself and the aides came, they were educated him on things that he didn't know about, which was helpful for him. So the education and letting us know what to expect, what to see. Is this normal? Is this not normal? Because nobody really knows. Yeah, this could happen, but it may not. Everybody's situation is different. So that was very enlightening and comforting. When my sister passed, the nurse came to pronounce her, and she helped me bathe her and take her tubes off and dress her in clothing that she wanted. And we did it while I prayed, and she just did loving strokes. And we sent my sister out of the house with dignity and respect. And it was just wonderful. It was a wonderful thing. I'm getting teary-eyed. That ritual of loving on your loved one when they're gone it was so impactful. After she passed, we received calls and calls and letters, cards from the bereavement team. She's been gone since November of 23, and I still get cards from the bereavement team. I still get calls. Are you okay? We have bereavement group. We have this. What can we do for you? They'll send a pamphlet to us. So they're making sure that it's not just about the person in the bed. It's about the family, and they're trying to meet all the needs. They told me when my sister came home, because she was coming off dialysis. I forgot that. She's on dialysis. So she had tubes everywhere. They said, coming off dialysis, we expect her to be 1 week to 2 weeks. If she's 30 days, it will be a miracle. And my sister lived a miracle in a day. And I appreciate all the care that they gave. And I think it is because of the care that they gave.
Right.
Now, my ex-husband was diagnosed with esophageal cancer in February, and he was in the hospital. He had 1 round of chemo. It was the super powered chemo that you're not supposed to have any kind of radiation, and that chemo killed his body. The cancer didn't, the chemo. It created blood clots and things like that in him. And he was in the hospital, and he made the decision to go on hospice. He said, I don't want to live like this. And as a doula and as a person that cares about him and as his advocate, it's my job to honor his wishes. I could say you could fight, but if he doesn't have the fight and he's made his decision, it was my job to support him. So come, let's go on hospice. He didn't want to come home. He wanted to go into the facility. We have a local facility here in Frederick, and they didn't have a bed for him. I said, come home. When they get a bed, we'll put you in. They were full. Hospice was full. So once he got home, he decided to stay. He didn't want us taking care of him. He didn't want the memories of him in the house. We handled it, and he got great care. We had a wonderful care nurse, wonderful caregivers. The love that came out of their hands as they washed him and cleaned him and made him, it was touching to see. We also used caregivers from Assisting Hands to be there during the day with my daughter, so she wouldn't have to clean her father, and to support her. Again, education from the caregivers at Assisting Hands, the aides from hospice was so impactful on my daughter, because she wasn't around all the time with my sister. I can say whatever as a death doula, but when it comes from somebody else, they seem to hear it. My ex-husband and I were on great terms. I was his person. I was his power of attorney, his executor. When he knew it was his time, he sent everybody home. And he just wanted it to be me and him there. So again, when he passed, I washed him, and I called hospice and said he had passed, and they said a nurse would be there in an hour, and they were there in 15 minutes. You need them, they're there. Also, medications. If you're running out of medications, the nurse will bring the medications to you. So you don't have to worry about running out and going anywhere. There's no wait. They know your need and they know that your need is urgent. They'll get you whatever supplies you need so that it's not an expense on you. It was just an amazing experience.
Yeah, and that is one thing to point out, that one of the things that hospice does provide, it provides incontinence supplies, it will provide an oxygenator, it will provide a host of supports to make you comfortable in your home so that you're not having to pay for them out of pocket. They will also take care of all of the medications. Their nurse will come in and make an evaluation of which medications to stay on and which ones to come off of, which I think is great in terms of a lot of times people continue to take a cholesterol medication and they're on hospice and it's causing joint pain. Maybe that's not something that they need at the end of their days in order to feel they're most comfortable. For me, one thing, how I got into this really, when I started, is both my parents had cancers up in New York, and they both died in hospitals plugged into machines because no one ever mentioned hospice. Now, I don't know what they would have chosen, but I was a real estate lawyer. I didn't know anything about hospice. My brothers were not in the medical world. We didn't know. And their doctors at that time were oncologists who don't give up. And my dad was given, your story, the option to go on yet another round of really aggressive chemo. And it's what wiped him out. And so his last 6 months were painful in the hospital, and he got shingles, he was miserable. But maybe had he had a conversation about hospice, he would have been able to come home to be with friends and family and have a better quality of life. But he didn't get that shot. And so that's why this is so impactful to me, to have this conversation, to educate people. And it's why I started Assisting Hands, because one of the things that's critical is hospice does a lot, but their aides maybe can come in a couple days a week for a thing, to help with a bath or to spend an hour chatting. Assisting Hands can bring in caregivers who are there the other 160 some odd hours of a day to give a family a break, so that they're not the ones that are washing. The last thing you want to do is have your son take care of your mom when that's not something that either of them wants, as a general rule. And I can speak from that from personal experience as well. That is, my mom once fell in the shower and I was there, and it was uncomfortable for both of us. It was something we never spoke of again. Sorry, Mom, for mentioning that. That's the thing, how home care can partner with hospice and with death doulas to fill in the gaps, to give the family a break so that they can live their best lives. And oftentimes, the patient doesn't want to be a burden to family. And so having professional caregivers can come in to spell family members is also very important and something that's super impactful. I see a couple of questions in the chat I'm going to address. One is hospice covered by insurance? And so Dawn, I'll let you address that one.
Yes, it is always covered by insurance. Now, there is sometimes a deductible that needs to be met or a copay depending on your insurance. Medicare does cover this as 100%. Your Medicare Part A, which does the hospitalization, goes away and it becomes hospice Medicare, and they cover everything. Equipment, medications, all of the services we talked about, all of that is covered. Supplies. If you're on private insurance, hospices like ours is nonprofit, and we have generous donors throughout the community. So we don't charge for our hospice. We take what the insurance gives us, and we're grateful for that. But we also understand that you've had enough stress, especially if you're not under Medicare, and you're possibly very young. So we don't want to go ahead and throw another barrier into having hospice services to you. So thank you for our incredible donors in the community that help us. And most hospices are they're all either profit or they're nonprofit. All of them have generous services. So it really depends on where you're at and what hospice you're looking for to discuss that, if that is going to be a factor of cost.
Thank you. So another question is it better to have hospice at home or hospice in a community. And I'll say a little bit and then I'll turn it over to the two of you because you've had both experiences. Every county is different. And so Montgomery County, where Assisting Hands is, the real push is for hospice at home. And there are some small facilities, but it's really driven to have people have hospice at home. Other places, it's different. And so what's better? I think it really depends on your family situation and what you're capable of doing. I know my dad could not have taken care of my mom on hospice. He was not that guy. He was a man of that generation. He knew how to bring home the bacon, and then my mom knew how to care for everybody. But he could have had home care to supplement it, and maybe he would have, I don't know. But he might have felt more comfortable not having his wife pass at home. Again, I think it's very individualized, depending on the family and the circumstances and who's around. Tina, any thoughts from you since you've experienced it both ways, it sounds
Both
like?
ways. I think there is no right way, there is no wrong way, and you should not let anybody make you feel that there is. There are some people who say, how can you put them in a facility? Why don't you have them at home? Maybe you don't have the energy to do that. Maybe you're not physically able to do hospice at home. It's okay to put them in a hospice care thing where you go over and take care of them, and then you go home and take care of yourself. Like Steve said, depending upon your family dynamics, what support you have at home, who can help you, your financial status as to whether you can bring aides in or not, the right decision is the best decision for your family.
All right, Dawn, you want to add anything else?
I agree with Tina. We happen to have in our Frederick Health Hospice has a residential hospice that is in Mount Airy, Maryland. And it is not for patients, it is for patients where caregiving has just broken down, or you just have decided, like your father, who says, you know what, I'm not comfortable with my wife dying in my home or either providing that care, and I would prefer to go somewhere for hospice services. The level of some people say, I want to die in the hospital. And sometimes you qualify for that, sometimes you don't. And Medicare says you have to go somewhere other than the hospital. And that's a conversation we have with patients before we even start hospice services of where you would want to be. And then we always come up with a backup plan because people need a backup plan. And that's what we do. Hospice is all about planning in a crisis. And that's what we take care of. So a lot of conversations happen at home. Home is beneficial because you don't have to go anywhere. You don't have to find a parking space. You can just stay home. You can hire people to come in. Frederick Assisting Hands and in Potomac Assisting Hands, we work with both of those agencies and many other home care companies to allow people to have that supported home. But often we see people just wanting to take care of each other. I tell them to put up that shingle saying, I need help, and let friends come in and let church members come in and let your community help you. And sometimes that can be really beautiful. But we understand that sometimes taking care of a patient at the end of their life is really hard, and you might need some extra support.
Gotcha.
A lot of people will say, what can I do? How can I help you? And we say, oh, I'll let you know, but we never do. Most of the times we never do. So create a list of things that you will allow people to do for you, whether it's walking your dog for you, cutting your lawn, taking your trash out. They want to help you. They want to be a blessing to you. And it's okay to let people help you.
Great. That's a great thought because a lot of people don't want to be a burden, but the reality is it's a gift to others to allow them to help you. So
Yes.
there's a bunch of questions in the Q&A, so I want to get to them. I'll read them off because some I can answer, some they're probably for Dawn or Tina. First one is, if I'm on hospice and I'm dying from cancer, but I get COVID, can I get Paxlovid or some other treatment?
Yes, you can. As long as you can still swallow and it's not causing you any additional harm, absolutely you can.
Okay. And there's a question about the home aides and what's covered and what's not covered. So I'll address that, and Dawn, you can jump in. So we're talking about two different aides groups here. One is private duty aides that are brought in by someone like Assisting Hands. And so we are not covered under Medicare. We would be covered under long-term care insurance, not covered under private insurance. There are aides that are brought in from hospice, and those aides are very limited in the things they can do and the amount of time that they can come, but those would be covered by hospice. And they would come in if somebody needed a bath. They would come in and help give a bath. But then they leave because that's the only service they can do. Where assisting hands, we might be there for 4, 5, 6, 10, 12 hours to assist with a range of activities. So anything else to add to that?
No, that's perfect.
Okay. Next good question was, let's say I want my loved one to get private PT or a personal trainer, and I'm happy to pay for it. Does that affect my ability to be on hospice if I want to provide supplemental services and I'm prepared to pay out of pocket for?
Absolutely not. I actually was working with a patient up here, and they did have a personal trainer. She had Parkinson's, and they were working on Parkinson's training with balancing, all paid out of pocket and placed on hospice service, and certainly continued that. One thing that often happens though is she had told the hospice nurse that she was exhausted and she was tired. So the hospice nurse had to go have that conversation with her daughter saying, I'm not sure if continuing the physical therapy that you're getting is in her best interest. She says she's getting tired. Maybe we should back off of that. And it took a moment to have that conversation because often families don't want to disappoint the patient and the patient doesn't want to disappoint the family. So just make sure all of your goals are in line. But we support any kind of activity at all. We actually encourage it because it allows you to go on vacations, which we help cover. A lot of things that we do to make your life have the highest quality as possible.
Here's one. It's a sort of a multi-part answer, I think. So I'm going to read it and then we can bat it around a little bit. It says, all of this is fine, but where do you start? If the doctors are still trying to figure out what is wrong and how to help, but you're short of breath and can't resume activities that give you pleasure, kind of what do I do? Where do I turn? Is hospice, I'm now embellishing, but is hospice even an option at that moment? Dawn, what are your thoughts on that?
So I always look at your functional status. Are you short of breath and are you on oxygen? Are you often having to sit down to catch your breath? Are you unable to really have a day where you feel that you're not anxious and you're struggling? If you're at that point and the doctors still are trying to figure things out, it's okay to say, I'm not sure it's going to help me if you figure this out. Even if you figure this out, I'm not sure I want that treatment. So could I talk to someone? And hospice information is always non-committal. So you can reach out to our hospice or to any hospice and say, I'd like to have some information. We can review information from your doctor and have a conversation with your doctor. And hospice isn't just a stamp that you have this disease process. Sometimes it's multi-factored that are the reasons you're going into hospice. So just make sure you're communicating with your provider. And if you feel like you're not being heard, you can always self-refer to hospice services.
Okay.
I would say also if they haven't come up with a solution, they haven't suggested hospice to them, ask them, am I hospice, what is the word I'm looking for?
Appropriate?
Appropriate. Yeah. Am I hospice appropriate? And then it may be a wake-up call for them to say, oh, maybe I'm not finding things fast enough. Maybe I need to review what their goal is. Maybe I need to educate them more. So sometimes doctors don't know what to tell you until you ask them the questions that let them know what you want to know. So ask your doctor, what is this treatment? What is my outcome? What's the best case scenario? And again, am I hospice appropriate? And that may be a key to get them moving on the care that they're giving you.
Great. So one other question, and I'm going to answer the question, but I'm not an expert, so you may want to, and Dawn, you may have some sage. One question is, does Medicare make you sell your home and run down your assets before it will cover longer hospice? And the answer is absolutely not. Hospice is disconnected from sale of assets. Medicaid may have a different rule, but Medicare does not impact that. Along the same lines, hospice has a 6 month sort of expectation, but you can be renewed multiple times. So hospice will continue to cover you as long as doctors still believe you are hospice eligible and hospice appropriate, and they will reevaluate you at that 6 month mark. We had a client that was on hospice for 2 years. And look, doctors are very bad predictors of people's last day. Unfortunately, we don't get an expiration date, so doctors are making their best guess. In this particular case, the daughter said to me, why my mom is still on hospice? And I said, no. She goes, the devil won't take her. All right, fair enough. She was a feisty lady, I will say that. But it was 2 years before she finally passed, and the hospice continued to pay because she continued to be hospice qualified. Either of you have more to add? Because I have another really interesting question that I am clueless on.
Well, doctors are practicing medicine. They're practicing it. They haven't perfected it. So they don't know. They don't know when the time frame is. So they're doing the best guess that they can.
All right, so here's a good one. If you're in a state that allows assisted suicide, can you be in a hospice and then elect assisted suicide? Does being in hospice complicate the process? My first thoughts on this are, you can always unenroll from hospice, right? It's a choice. You do not have to be in hospice. You can say, I don't want to be in hospice anymore. Now, you lose all of the benefits that hospice provides, but that is your choice. So I don't know the answer to this question more specifically. Maryland does not have an assisted suicide law. DC does, but I'm not that familiar. Dawn or Tina, any thoughts on this one?
Oh, I have no basis to respond.
Maryland has had a lot of legislation in the past few years about, they call it MAID, and medically assisted suicide. Can't think of what the words are, but it's suicide because you have a chronic illness or a cancer that can't be cured. But I feel that, like you said, Steve, I would disenroll from hospice care to get that. I don't think that they can't go hand in hand, because that's not something that we believe in. Yes, thank you, Sandra. Medical aid in dying. Woo! So simple, and I couldn't get it. But I feel that if that is your choice, then you can have hospice while you're going through that process. You can have hospice and enjoy that quality of life that we hope we provide to you until you're ready to make that decision that you would like to have that physician-assisted suicide. I feel like there's no reason why you wouldn't be able to do that. We have people sometimes, as far as revoking hospice, they just want to have that last time with an oncologist, just to make sure that there's nothing there. And they revoke hospice and come back on board. So you can go through that process if you choose and have hospice. And if you decide that's not the right decision for you for whatever reason, you can always re-enroll back into hospice services.
Yeah, and this is Steve Gurney from Behind the Curtain. Just with a little bit of research on medical aid in dying, if you're in a state where medical aid in dying is legal, you can be enrolled in hospice and later decide to pursue medical aid in dying. In fact, the majority of people who use medical aid in dying are already receiving hospice care, about 90% in Oregon, for example.
We did have a client, thanks, Steve. We had a client who was in Maryland. He had ALS. He was getting ready to enroll in hospice in Maryland, and instead he decided he would move to DC to take advantage of the DC assisted suicide law, or medical aid in dying law. And that's what he did. We helped transition him to DC, to an assisted living community. He got the qualifications that he needed, and he did end his life on his terms. To me, I think it's, you have choices, and there's nothing that limits you to one. You may have to head down one path. But it sounds like a lot of times you can back up and move down a different path if you think you've made the wrong choice. I know we have a few more minutes, Steve. I see one new message in. Okay, this is another interesting question for you, Dawn. Can a person who decides to stop eating and drinking to accelerate their dying remain under hospice care as a hospice patient?
Yes. Yes. I feel that hospice is the one service that you have autonomy in. And that is something you choose. Now, if your family chose to not allow you to eat or dying, that's to eat or drink, that's a whole nother conversation. But if you've chosen that and you've chosen to stop taking your medicine, you've chosen those choices, then we're still going to support you because it is about what you want. It is not about what I want. It is not about what the medical community wants for you and decides for you. This is the one opportunity that you have to say, I choose this or I choose that, and I need support during this time. So I would hope that no one would ever feel that if they choose that they want to die faster, often I can't help you with that. But if you choose to not eat or drink, I'm going to support you with that and offer you any type of emotional support that I can.
One note, thank you for that. One note I see in the chat, again, a story. We do home care. So we were in a hospital. We were working with a client who we had cared for at home. He went into the hospital. I went to go visit to see how he was doing and to see what we could do to help him when he returned home. And the family was sitting there talking about the expense of getting a hospital bed and the expense of getting all of these supplemental things and the cost of diapers and how expensive it was all going to be and how they were going to manage it. And he was end stage. He was dying. And I said to them, has anyone talked to you about hospice? And they looked at me like I had four heads. They were like, no, what's hospice? And so I proceeded to tell them, and I said, look, I guarantee you there is a hospice liaison in this hospital. If you call in the nurse and you ask her to bring that person in, they're going to satisfy all of your concerns and address all the things that you think you need because hospice provides it.
That's the one thing I forgot to mention in regards to my ex-husband is he was in the facility and we made the decision to go to hospice, and hospice came right in the room. They answered all the questions. They made all the arrangements. They knew what time the bed was going to be delivered. They took care of everything right there from the hospital before he left. I forgot that.
Hospice is amazing. And to the point of the person who put in a note, medical professionals don't mention it enough, either because they don't want to feel like they're giving up or they're afraid of how people will take it. But it is an important tool to evaluate, to give families a choice. This man, the nurse who was the charge nurse on the floor, was like, you could see how relieved she was that they had asked about hospice, but yet no one in the hospital was prepared to tell them about it, which to me was like, why am I the home care guy being the one to bring this up? That's not the way it should work. And so we have a lot to do to educate our medical community. And that's part of the reason for this talk, is to help educate people, because it's a tool in someone's tool bag. They don't have to accept it. They can always say no. And it's no shame on a doctor or a nurse or a medical professional for suggesting that it should be a conversation. It doesn't mean they have to give up. It doesn't mean they have to stop. They could say, no, I don't want to go on hospice. Doc, I want that next round of chemo. Nothing stops them from doing that. Hopefully people will take away from this. This is just another very important health tool that people should know about and allow them and family members to evaluate its benefits and detriments. Dawn, I'll let you weigh in on that one.
No, thank you. I completely agree with you, Steve. I feel, and our hospice feels it's important to empower our patients. So in the community, not our hospice patients, but all of our community. So we've partnered with two medical systems, one in Frederick and one in Montgomery County. And we feel that it's so important we staff that office in the hospital 7 days a week. So if you have a question, then you can ask for someone to come out to your bedside immediately. And you don't have to go with our hospice, but let's get the conversation started. We also, as to Eileen's comment, education is so important. And education means our nurses need to be educated in the community, in the hospitals, that you don't have to be on your last moments before hospice comes in. Physicians, talking to them, making sure we're in good communications with our cardiologist, our pulmonologist, our oncologist, making sure that we're constantly staying up to providing additional CEUs and education for them is important. And then also going into the skilled nursing facilities and letting the skilled nursing facilities know that if a family really is at a point where rehab is, they've met their goal and they're not going any farther, but they don't want to go back and forth to the hospital, they could be discharged on hospice services. We just feel it's so important. So the liaisons in the community, I feel, are a huge impact on providing the education to everyone.
Great. So I know this is one question that we get asked all the time. So two things. One, how home care works with hospice is, so we view that when we get brought in and hospice is on board already, or we are asked to help bring them in, they become the sort of the quarterbacks. We coordinate with them. Our nurse will coordinate with the hospice nurse to make sure that we have the best plan of care for that patient, to make sure that they are the most comfortable, they get the things they need. So we work very collaboratively with hospice to ensure we're providing the level of support that the client needs. And if a hospice nurse comes in and sees a change in condition, they will reach out to our nurse to make sure that we're updating our care plan and re-educating our nurses and our CNAs on what additional services need to get provided to a client. So it is a great opportunity to also relieve the family from some of that responsibility as well. Another question that was asked is, can I still call 911? And the answer is yes. But Dawn, you're on mute.
Yeah, sorry. Yes, you can. 911 is not what we want you to call if you have hospice, because we can come out in the middle of the night if you need us. It is not a problem. What we do is if you call us, we're going to tell you what to do right away. We're going to come out, plan to come out if you need us. But often what we tell you is just the ability to take care of the problem, and everybody can get back to daily living, going back to sleep, continuing with your day. But on those cases where you want to call 911 or someone panics and calls 911 and you're transported to a hospital, once you've notified us, we're going to have a conversation with you and say, what is your goal? Do you want medical treatment? Was it just a moment? Do you need to be admitted to the hospital under services? What can we do to help you? So making sure that those communication lines are open at all times. And that goes right back to that collaboration of care that you were talking about. Communication and collaboration of care is the success of a good hospice experience.
I also think it's very important that your wishes are known to your family members, that they know what your plan is. Sometimes the sisters say, like, let's fight, and the son honors the family members, the hospice patient's wishes, and then they get into a thing. You got to make sure what your goal is, what your commitment is, what you want done is known by everybody.
One other question, and I can answer it a little bit, and maybe Dawn, you have more input, or Tina. Is there a list of places you can go if you don't want to be at home in the DMV? And is there a Medicare rating for those skilled nursing facilities which also do hospice? I'll give a little bit for Montgomery County, but Dawn and Tina, you can probably flesh it out. So in Montgomery County, there really is one location that is owned by a hospice facility that you can go to for in-resident hospice care, but it's generally for very short term, and it's for people that can't be well managed pain-wise at home. I know Frederick Hospice also has a location, but it's in Frederick, it's in
Mount
Frederick,
Airy.
that someone from Montgomery County could go to, assuming there's room availability. And a number of communities, if you're in a skilled nursing facility, you can be on hospice in that community. I don't know if there's a specific Medicare rating for hospice communities, but Montgomery County doesn't have a huge network of standalone hospice beds available. It's very limited, and I don't know about the other parts of our area. So Dawn and then Tina.
I was just going to say, Steve Gurney, in your resource book, is there not a listing of hospice places?
Yeah, it's there. We do have some. It's not 100% comprehensive, and I'm just dropping in the link to the Medicare Care Compare website for everybody. Their hospice is included on that comparison tool now.
Okay, good. Thank you. Dawn?
Yeah, that's what I was going to recommend, Steve, is the Medicare Care Compare. You type in your county that you have, and then all hospices are listed that serve your area, and they're listed on a star rating. And then to take matters into another level, you can look at facilities. Casey House in Montgomery County, who you were speaking about, is what they call an inpatient level of care. So you have to have severe pain or severe symptoms that can't be managed at home. That's the same level of care that is a hospice, like a hospital level of care. So we use Adventist Health and we use Frederick Health for our inpatient level of care, and Montgomery Hospice would use Casey House. So you can pick whatever you want. But to have that daily, what they would call custodial care, where a hospice is caring for that only one that I know of is the Klein House. It's a residential hospice. But you can also have hospice at any assisted living. You can have hospice at any skilled nursing facility. Unfortunately, Medicare does not pay for the room and board when that happens. So you do have to take that in effect. They pay for the hospice, but they don't pay for the actual room and board. So that can be complicated, but that's why most people wish to have hospice at home, because you're not paying room, you're already paying room and board. It's the care level that becomes complicated. So if your care is broken down, that's where the team will help you, social workers will help you find a place that you can receive care at the end of your life, because you deserve that.
Gotcha. Steve, I realize we're probably out of time, so I'm always mindful of that. Again, thank you both Tina and Dawn for your presentation today. Super helpful. I hope that we have helped educate and add value to people. Brett, thank you for being part of the Assisting Hands family. And I know, Tina, you had help from Assisting Hands in Frederick County. And Steve,
Yes.
as always, thank you for being our host and providing a platform for us to get the word out on a variety of important topics.
Sounds great. And I will get this up online at proaging.com and in podcast format as well later this afternoon. And we'll look forward to the next one. You always bring some great panelists to the table, Steve. I really love working with Assisting Hands and the panel members that you bring to us.
Thanks so much.
All right. Everybody
All right.
have a great weekend.
Thank you.
Thank you. Bye-bye.